Well, hi, and thank you for joining us for today's Mayo Clinic Facebook Live. My name is Dr. Joseph Dearani, and I am the chair of cardiovascular surgery at the Mayo Clinic. And today we are going to be talking about heart valve disease and the different options for treatment that could include a cath lab or an operating room. We will be taking your questions throughout the broadcast, so make sure to post your questions in the comment section below. So joining us today is my colleague, Dr. Juan Crestanello, and Dr. Rick Nishimura. Dr. Crestanello is a senior cardiovascular surgeon and professor of surgery at the Mayo Clinic, and Dr. Nishimura is an esteemed cardiologist and professor of medicine at the Mayo Clinic, and also the chair of Mayo's structural heart disease program. So Dr. Crestanello and Dr. Nishimura, thank you so much for joining us. So let's start our discussion with heart valve disease. Dr. Nishimura, could you talk to us just a little bit about the valves in the heart and how, as a cardiologist, you sort of categorize these and how patients should think about it?
Well, let's go ahead and start kind of giving an overview on physiology, how blood goes through the heart. So let's go to this first slide up here and talk about how the blood comes from the body to the heart. So you see the blue section, that's the right side of the heart. And blood comes in from the body to the right side of the heart. You see it goes to this right atrium, goes through the tricuspid valve into what's called the right ventricle. And the ventricle is the pumping chamber of the heart. The blood then gets pumped through the pulmonary valve and goes into the lungs. In the lungs, it then becomes oxygenated and returns back to the heart, and that's where you see the red. So you come in through the pulmonary veins to the left atrium, which is the top part of the heart, goes through the mitral valve, and goes down to the left ventricle, which is the pumping chamber that pumps blood to the rest of the body. Once the left ventricle pumps, blood then goes out the aortic valve to the aorta and rest of the body. Now, if we think about the valves and what the valves do, the valves are kind of like one-way doors. So if you think about it, if blood comes in, let's say from the lungs to the top part of the heart, which is the atrium, you've got this mitral valve here. And the mitral valve is supposed to open like a one-way door so that blood goes from the top part, the left atrium, to the left ventricle. Then when the pumping chamber pumps, the valve's supposed to close like a door. And then blood will go out this other valve, the aortic valve, to the rest of the body. So what happens is these valves have to work. They have to open, let blood through, and close, block blood from going back again. And there's actually two problems that can occur. The valves can either leak or they can block off blood called stenosis. So if they leak, for instance, if we have this left ventricle that's pumping and the mitral valve's supposed to close, when the ventricle pumps, the blood will go backwards into the left atrium to the pulmonary circulation and cause problems. If you have this aortic valve here, when the ventricle pumps and blood's supposed to go out the body, if the valve is what we call stenotic or doesn't open well, when the left ventricle pumps, blood just can't get out the rest of the body. So you've got four valves, tricuspid and pulmonary on the right side, mitral and aortic on the left side. Supposed to work like a one-way door, but you can have leakage called regurgitation or blockage called stenosis.
So let me ask you, Dr. Nishimura, patients sometimes ask whether or not this valve problem that they've gotten is because of something they ate. Could you just comment a little bit on the difference between a valve defect that they might have been born with, a congenital defect, or an acquired defect that may or may not have anything to do with something that they ate or did or were exposed to?
So as opposed to some of our other cardiac diseases, such as like coronary disease, where not having a healthy lifestyle and smoking and eating the wrong foods can affect the problem. The valves are usually something you're either born with or you acquire during life. And you can be born with an abnormal number of cusps of a valve that either leak or stenose. You can develop rheumatic fever. So as a child, if you get strep throat, it can affect the valves, and long term it can cause a problem. Or it can just be a function of aging. So it's usually never anything that a person has done, but just the result of what you were born with or what might have happened during your lifetime.
So, Dr. Crestanello, so obviously now we've heard a little bit about the valves, and they can become dysfunctional, they can be narrowed, or they can leak. Tell us a little bit about what the options are, basically the options of either repairing valves or replacing valves, and what would be preferential for one versus the other.
So once the valves are functioning abnormal, the two options are either to repair them or to replace, as you said. In terms of the valve repairs, we have they're advantageous because in those situations we can maintain the normal structure of the valve, and in general, patients do better with a valve repair than with a replacement over time. In terms of the replacements, those procedures can be done either through a conventional surgical approach, and now we have technologies that allow to do those procedures as well through a minimally invasive approach, or going through a small puncture in an artery or in a vein. So there are several options to treat valve disease, either through conventional surgery or through percutaneous approaches.
Okay, so we will come back to maybe what an incision would look like, but let me shift back to Dr. Nishimura. So you were recently actually one of the point people for the guidelines for the management of valve problems with the American College of Cardiology and American Heart Association. What would you say would be the most important, lessons or teaching points that actually the patient community should be aware of as opposed to the medical community?
So there was a lot in there, but I think the two most important points is number one, it's critical to identify upfront patients who have valve disease so they can get the evaluation and care they need. A lot of patients with valve disease will continue to be what we call asymptomatic, can do their normal activity, and might not feel any problem at all, but they can have significant valve disease, which can be detrimental in the long run. And valve disease is picked up by a good general examination because doctor will, or nurse practitioner or physician's assistant will be able to hear a murmur. So that's why it's good to go for an evaluation once a year or once every other year and have your care provider listen to you. And if there's a murmur there, then more needs to be done. So the first thing is the initial detection. Now, once it's detected, you'll go through a series of tests, and if you have a valve problem that needs to be fixed, the second important thing that came out of it is the concept of a valve team. And a valve team consists of a cardiologist, a person who might do an echo, and the cardiac surgeon, who all kind of have an expertise in valve disease and work together to determine the best approach for the patient. So I think that the valve team is something that's fairly new, but it's very important for anybody who has valve disease to make sure you get to a proper valve team.
Okay, all right. So, Dr. Crestanello is a surgeon. Dr. Nishimura, you're an interventionalist, so you both do procedures on patients. What would you say if you had to counsel patients and their families when they are being interviewed by a surgeon, they're contemplating a procedure, they've been told that something needs to be done? What would you say are the questions that they should be asking you? And what are the things that you think are very, very important that you need to make sure that he or she understands before actually, undertaking either an operation or an interventional procedure?
Well, I think that the most important is the first step is to really understand, what's going on with that valve or whatever surgical problem that is going to be the issue to address. So they need to understand why they have this valve disease, what is the consequences of that abnormalities in the valve that is having either causing their symptoms or causing their change in the heart. And that's the reason why we recommended to have a procedure. Also, they need to understand what that procedure consists of, how long it's going to take, what is the recovery time, what is the risk associated with that procedure, and what what you're going to gain with that procedure, particularly in the sense of I'm going to feel better. This is going to change my my ability to do things. It's going to improve my lifestyle. It's going to improve my life expectancy. And also, it's very important to understand what is the expertise of the surgeon or the interventional cardiologist who's going to do the procedure. What are the outcomes of that institution or that group of surgeons or interventional cardiologists who are doing the procedures, and as well as the recovery time and all the issues, particularly with outcomes. I mean, what are the results of that group? That's very important.
So, Dr. Nishimura, in your particular situation, I think to most patients, probably maybe almost all patients, there's obviously enormous enthusiasm for the least invasive way to try to solve their problem. And of course, with all these catheter-based approaches for valve replacement, in some cases valve repair, I mean, for you as an interventionalist, what do you think the patient community, should really know? Because on the surface, it sounds like that would be the best answer,
Yeah.
but you and I know that sometimes it may be better off to actually go in the direction of surgery as opposed to a catheter-based procedure. What do you think?
Well, I think every patient should be given a choice.
Yeah.
And there's option. In every situation, there's different options that can be taken. You can do nothing. You might say you can do surgery. You might say let's do a catheter therapy. But then it's up to, like, the team I talked about.
Mm-hmm.
So the surgeon and the interventionalist and the cardiologist to get together and sit down with the patient and family and say, listen, you've got these choices. Here's the pros and cons of each one. And let's see what your preferences are, and together we'll make the decision. But I don't think there's any valve disease in which you say you have to do this one thing. There's always choices there, and I think as patients and families, you should always ask, what are my options, what are my choices, and what are the pros and cons of each.
Right. And I think we practice that, I think, really quite well here.
Yeah.
Let's shift a little bit to the timing of these interventions, because there was we referred a little bit earlier to the fact that some patients, may be asymptomatic. Let's talk about what you think through the eyes of a cardiologist is the best way to judge when the intervention should be done, with particular attention to the patient that may actually feel quite well and may have no symptoms at all.
Yeah. Well, definitely. I mean, if you have symptoms related to valve disease, something should be done, if at all possible. The worrisome thing is a person who has severe valve disease, let's say they have a leakage of a valve, and they're feeling good. They might not seek any care, but for instance, if you have what we call mitral regurgitation, so when the left ventricle pumps, there's a whole lot of blood going backwards into the left atrium and lungs. It means that when it fills again, you've got twice as much blood. So that heart muscle is actually working overtime. It's like a car going at 10,000 RPMs all the time. And if you have a car going at 10,000 RPMs, at some point in time, that engine's going to give out. And if the heart muscle starts to fail, then you've missed your opportunity to do something. So anybody who has significant valve disease should undergo a thorough evaluation, so we don't miss that opportunity to save that heart muscle from wearing out.
Mm-hmm. Yeah, agree. How about, Dr. Crestanello, from your standpoint? I know, as you know, we're surgeons. What do you not like to see? I mean, we have the asymptomatic patient where I think an intervention might be contemplated even earlier if the valve can be repaired, which would be more appealing for the patient. But what about the patient where perhaps we might have waited too long? I mean, what do you, when you're seeing a patient that you really say to yourself, boy, I wish that I had seen this patient 6 months ago or 1 year ago? What would be the things that would be concerning to you when you get brought into the equation?
Obviously, heart disease and valvular heart disease is a gradual process. I mean, it's very rare that these patients go from completely asymptomatic to having end-stage heart disease. But so therefore, it is very important that the patients consult early on, as soon as they have some manifestations of heart disease, or if we know that they have valvular heart disease, and we know that it's important that we know the magnitude of that heart disease and the repercussion that is having in the pumping chambers of the heart, to try to catch them early. Because once the patients are in an advanced stage and they present with advanced symptoms of congestive heart failure, for example, swelling on their legs, or a significant amount of shortness of breath, that will prevent them from doing their daily activities, or may end up put them in the hospital with a ventilator because they cannot breathe. Those situations are in general situations where even though we were able to treat the valve disease, the repercussions that valve disease had on the heart are usually irreversible, and that is going to compromise the quality of life as well as the length of life of those patients down the road. So it's important to detect all these things early and try to intervene early in these patients before we get into a situation where
stage.
Yes.
Before we just take a moment to see some models and some pictures here, Dr. Nishimura, I know that the patients will sometimes ask me when we're on this subject of timing of surgery, about waiting and am I at risk of dying suddenly? What would be an example? When would it be okay to do watchful waiting, and when is it very, very clear that the risk of sudden death is a real thing, and that proceeding with intervention would be the safest course of action?
Yeah, so it depends on the valve,
Yeah.
because there's some valve diseases such as aortic stenosis, where the aortic valve doesn't open well. That's once it's severe and they get any symptoms at all, they're going to be at risk for sudden death, and you should move quickly. The other ones probably don't have this risk of sudden death, but they have that risk of the heart muscle starting to fail, and at that point in time you should be intervening earlier.
So if we're in this watchful waiting mode, is it okay for them to exercise? I mean, I think it also probably depends a little bit on the specific valve lesion, but in general.
In general, I never tell a person not to exercise. The worst thing a cardiac person can do
Is become sedentary.
That's right, because your body, you got to have your body in great cardiovascular fitness in order to, number one, accommodate valve disease, or number two, if Dr. Crestanello is going to do an operation, the operation is going to go much better if they've been conditioned.
As much as they can.
Yeah, that's right.
Let's shift. Let's take a look at the diagram of the incisions that we can use. And Dr. Crestanello, maybe you could just point out a little bit about the variety of incisions that are available, and then after that we'll have Dr. Nishimura talk a little bit about catheter-based approaches where there is no incision at all.
So here we can see three diagrams. In the center is the traditional approach, which is called a median sternotomy, and that black line represents the traditional incision. And that's something that we rarely do anymore. Nowadays, most of the isolated valve procedures are done through incisions, even through the midline, that are half or a third of that that incision. I normally tell my patients, for example, when I replace the aortic valve, that the length of the incision is going to be the width of my hand. Other alternative approaches are through a thoracotomy, and that's the image on the upper right hand side, where we can see that there's a large incision on the lateral wall of the right chest. That's the conventional approach. Nowadays we can do again an operation through an incision that is about 3 or 4 finger breadth, which is significantly smaller than that one. And finally, on the upper right hand side, we can see the robotic approach, where we can do this surgery basically completely endoscopically through 3 or 4 small port incisions, each one the size of about 1 centimeter, and a 2-centimeter incision in the middle of the chest that help us with the access, and that's what we call the working port. So overall, the size of the incisions and the options that the patients have in terms of the different approaches has expanded over the last 10 to 15 years.
Mm-hmm. Why don't you show us, before we take questions, Dr. Nishimura, why don't you show us, of course, what is the most desirable approach, which is no incision at all.
So there's just been a tremendous change in the way that we can put valves in some select patients, and that's called by a transcatheter therapy. So basically what you have a little catheter about this big, and there's arteries that you can enter in through the leg or through the wrist, and basically what you do is you just, while the person's awake, you're sedated, so you're feeling okay, but you're awake the whole time. You just take some catheters, you insert them into the artery. The catheters go in the artery. They go up around here and then into the heart, like that. And so your catheter will go on down through the artery, come into the heart, it goes across the valve, and then this artificial valve here, which was on the catheter gets inflated and the valve expands. You take your catheter out and then you have a valve in place. It's called a TAVR, a transcatheter aortic valve replacement. It's kind of revolutionized the way that many patients with aortic stenosis are being treated. But again, they have to be selected very carefully to be able to get the best results.
And I see that you have some different valve types there. What do we have?
Well, we've got, for instance, this is it's called a self-expanding valve. It doesn't take a balloon. This one here takes a balloon. Actually, the others you see are those that you put in as surgeons. You might have Dr. Crestanello kind of look at that and tell us the difference between the mechanical and the tissue.
So here we have, so basically there are two types of artificial valves when we have to replace the valve. One is what we call mechanical valves, and the other one is what we call tissue valves. And there are several differences among them. The mechanical valves are made of alloy that is made of carbon, and basically I always tell my patients that are made of metal. And those valves, they last in general for a long time. We tend to say that they last forever, but they require to be on blood thinners. And normally the way that they're designed is they have two leaflets that open and close, and when they open, allow the blood to get out of the heart, and when they close, they prevent the blood from coming back into the heart. The tissue valves are made of biological tissue, either
we have that on the diagram up there too. So.
Yes, it's on the upper right side. They are either made of cow tissue or pig tissue, and those valves they have a limited durability. Normally they last about 10 to 15 years, but they have the advantage that they don't need to be on blood thinners. The patients don't need to be on blood thinners for a prolonged period of time, like they do or if they had a mechanical valve.
Right. Well, why don't we shift our attention to the audience now? Do we have some questions? So what are the differences in symptoms between coronary artery disease and valve disease? You want to take a swing at that, Dr. Nishimura?
Sure. Sometimes there's no difference. In each one of those abnormalities, coronary disease are kind of a blockage of the vessels supplying the heart, and the valve disease, as we said, are either there's stenosis or regurgitation. Both of them are putting stress on the heart, and in terms of coronary disease, there's not enough blood flow getting to the heart.
Mm-hmm.
So the heart either reacts by causing chest discomfort, or if the blood backs up to the lungs, causing shortness of breath. And both of those could be either one.
Mm-hmm. Very good. Okay, what tests should a patient have to detect heart valve disease? So maybe why don't you start, Dr. Nishimura, and then maybe Dr. Crestanello can make some additional comments.
Yeah, as I said before, the way to initially diagnose it is to go get a good physical examination.
Mm-hmm.
Have your caregiver use this old-fashioned thing called the stethoscope.
Mm-hmm.
But if he or she puts it on the chest and hears a murmur, then something further should be done. Once a murmur's heard, you're going to get your chest x-ray and your electrocardiogram, but the echocardiogram,
The ultrasound.
in which it's just a probe that goes on the chest, no needles or anything like that, bounces sound waves off the heart. We can actually look at the function of the heart muscle and the function of the valves, would be the test to get to really diagnose valvular heart disease.
So, Dr. Crestanello, what beyond an echocardiogram would you, as a surgeon, would be ordering, and for what reason?
Well, it's, other tests that are usually necessary to evaluate patients with heart disease is normally what we call a heart catheterization. And in the heart catheterization, we look basically for two things. One is to make sure that the patient doesn't have concomitant coronary artery disease, blockages in the arteries that carries the blood to the heart. And if they do, they will need some type of intervention at the time of the procedure to treat the heart valve disease. And the other type of information that we get from the heart catheterizations is to measure the pressures and oxygen levels in the different chambers of the heart that help us to quantify the severity of the heart disease and determine, together with the echocardiogram and the symptoms that the patient had, to determine whether the patient requires surgery or not.
And I know in some situations we also get CT scanning or MRI scanning, particularly if we're contemplating some of the catheter-based procedures, or if somebody's had previous heart surgery and we want to, get a better understanding of, what might be at risk with a reentry. Sometimes blood vessels can be dilated, the aorta related to valve disease, and you can sometimes get complementary information from these other scans in addition to the ultrasound.
Yeah,
Very good.
one other thing that I like to use a lot is a treadmill test.
Yeah.
Because remember, one of our criteria for determining whether or not you guys should intervene is whether or not they have symptoms. And a person might have just kind of gradually decreased their activity level during the years and not feel that they have symptoms, but we use a treadmill to get an objective measurement on how
What
they're
they're
doing.
doing, yeah. Great. Okay, what are the surgical options for a mitral valve cyst? Well, maybe I'll just make a brief comment. That's a relatively rare problem. And if it's truly a cyst, depending upon the size, it may or may not be, it may be observable, or it may require surgery. But I would say if it's really truly a cyst, it likely would be able to be treated in a way where the valve would be preserved. That would be the most important thing. And it's quite possible that it could even be done with a robot or a minimally invasive incision. Well, here's a classic question, and maybe Dr. Nishimura wants to comment on, is mitral valve prolapse a serious problem?
Yes and no. So the majority of people who have mitral valve prolapse, no problem at all. And it just merely means that the mitral valve opens, and when it closes, it kind of bulges a little back. And if it only results in a little bit of leakage, people do well and live the rest of their lives without a problem. But there are a few patients in whom the prolapse becomes so severe that the leakage becomes severe, and that is severe mitral regurgitation. In those patients, they should see somebody like you to be able to get that valve fixed, because that could be a serious problem in the future.
Great. Well, finally, Dr. Crestanello and Dr. Nishimura, what types of questions do you commonly hear during your consults with patients? I mean, what do our patients, more often than not, asking you? And I suspect that's a general thing, but maybe it's about the role of the operator and the expertise of the operator and experience, and maybe it's about something like the exercise or medicines or.
Yeah, I think when I see people, they've usually been for other opinions as to whether or not something like surgery with the two of you should be done. And I do talk about the experience of the operator. because the repair of a mitral valve takes a lot of expertise. And if I have a patient, I want my patient to have the best, and I want to make sure that they have an operator who's had great experience doing this. So that would be the most common question that I get asked.
Juan, from a surgery standpoint?
Well, I think that we have all type of questions, but I always say in these situations that what I always wanna, the message that I always wanna get to the patients and to their families is that we're here to take care of them, and that we're here for to restore their quality of life, that what it was had been if they didn't have the valve disease. And obviously they're going through a really stressful situation, because when somebody tells them that they have valve disease and they need a cardiac surgical procedure, that generates a lot of stress on them and their loved ones. So I think that the role of the surgeons, in addition of being a competent technician and pull them through the operation in a successful way, it is also to make sure that they understand the severity of their disease, but they also understand that they have somebody on the other side who really cares for them or for their family.
And I think just to close out that discussion, I think for me, one of the things that I've learned is that open heart surgery, even if it's with a small incision, there still is this fear amongst the patients that it's dangerous, and I think what I really try to reassure is that in the current era, cardiac surgery is very safe, even in patients with advanced disease. I think the technological advances, the anesthetic advances, the critical care advances, both before or after surgery, allow us to do complicated valve procedures and beyond that, really very, very safely in the current era. And so for the patients and their families, they should be reassured that for most well-established cardiovascular programs that include a heart team where we have cardiologists and surgeons talking, that all of these procedures can be done with really quite a big margin of safety.
I mean, open heart surgery is scary for anybody, but I will say that attitude plays a major role in how a person is going to do. And I think one of the things I sense is if a person's not ready for the operation at this time, you give them time to think about it.
Agree.
Because they have to come and say, I'm ready to do it. And if they have a great attitude and they've got great surgeons, they're going to do very, very well.
Great. Well, listen, thank you for joining us today for our discussion about treatment options for heart valve disease. This discussion will be on Mayo Clinic's YouTube channel for future viewing. So if we didn't get the chance to answer your question, we will try to do so after the broadcast. Thank you very much and have a great day. And my gratitude to Drs. Nishimura and Crestanello, my colleagues and friends, for a wonderful discussion. Thank you.